So the CXCR12 and CXCR4 chemokine axis underlies the interplay between cancer-associated fibroblasts, the cytotoxic immune cells, and tumor cells. Investigators from the Cold Spring Harbor Laboratory first reported the importance of this pathway nearly 10 years ago in a mouse study, where they demonstrated that blocking this pathway in combination with an antibody targeting PD-1 resulted in stabilization of tumors. The hypothesis is that CXCR12, a chemokine, which is released by cancer-associated fibroblasts, blocks infiltration of T cells into the tumor. Now, in the laboratory, we extended these findings in mice and demonstrated that addition of gemcitabine chemotherapy to CXCR4 and PD-1 inhibition was required for mice to live longer. Interestingly, mice treated with the CXCR4 inhibitor in combination with anti-PD-1 did not allow mice to live longer compared to mice treated with other control treatments. We also found that the ratio of CD8 T cells to regulatory T cells increased on treatment compared to pre-treatment tumor biopsies, suggesting that this combination was having a favorable effect within the tumor immune microenvironment. Now, with these preclinical findings, we proposed an investigator-initiated pilot clinical trial testing motixafortide, which is an inhibitor of CXCR4, cemiplimab, which is an anti-PD-1 antibody, combined with gemcitabine and nab-paclitaxel in treatment-naive pancreas cancer patients. So previously, motixafortide and pembrolizumab, either with or without 5-fluorouracil and liposomal irinotecan, was tested in previously treated metastatic pancreas cancer patients. In the initial cohort, where patients were only treated with motixafortide and pembrolizumab, only 1 of 37 patients experienced a partial response, with a median overall survival of 3.3 months in the intention to treat population. The trial subsequently added another cohort of patients where 22 of them were treated with motixafortide and pembrolizumab. However, in this case, patients also received 5-fluorouracil and liposomal irinotecan. In this cohort, 32% of the patients experienced a partial response, and the duration of response was 7.8 months. Conversely, our rationale in targeting CXCR4 and CXCR12 pathway in treatment-naive patients is to decrease the likelihood of additional chemotherapy-resistant pathways to dominate the tumor microenvironment. In addition, we favor the choice of gemcitabine-based chemotherapy given its immunomodulatory role in affecting regulatory T cells, which has been observed by us as well as other investigators. So we have translated our preclinical finding to a pilot clinical trial, which is based on a Simon 2-stage design, where 10 patients are treated with all 4 drugs and expected to achieve a response rate of 30% or higher within 16 weeks. If this criterion was met, an additional 30 patients were to be added in the expansion stage. Between November 2020 and March 2023, 11 patients were enrolled to this pilot trial at Columbia and Brown University. The median age of participants was 60 years, and 10 of 11 patients had liver metastasis. As of May 15, 2023, there were no unexpected grade 4 or grade 5 treatment-related adverse events. And as of July 2023, 7 of 11 patients, or 64%, experienced a partial response, and 3 patients remained on treatment. With a median follow-up of 13.4 months, the median progression-free survival was 9.6 months. Pre-treatment and on-treatment research biopsies were performed on all 11 patients and demonstrated an increase in CD8 T cell to regulatory T cell ratio in on-treatment compared to pre-treatment tumor biopsies, indicated a post-treatment favorable tumor immune microenvironment as we had observed in the preclinical study. Now, given this encouraging clinical data, the design of the study was amended to a randomized phase 2 trial testing motixafortide, cemiplimab, gemcitabine, and nab-paclitaxel versus the control arm of gemcitabine and nab-paclitaxel in a 2-to-1 ratio favoring the experimental arm. The primary endpoint is median progression-free survival, and the study is actively accruing patients at multiple sites. So the results of this phase 2 randomized study will give us additional confidence whether this treatment is truly efficacious in treatment-naive pancreas patients, which will then hopefully further guide a rational design for a randomized phase 3 registrational study.